what we'll be discussing today is cognitive behavioral therapy for relapse prevention. And as Rachel mentioned, we do have a little bit more of a focus today on mindfulness-based relapse prevention, and I'll explain that more in a moment. I do want to give credit to Dr. Lindsay from UNM's ASAP clinic, who originally developed the slides that these were adapted from. So our learning objectives today are to describe classical conditioning as it relates to substance use, to provide a brief overview of cognitive behavioral therapy, which is CBT, components and interventions related to relapse prevention, RP. And then we're going to review representative interventions from mindfulness-based relapse prevention, otherwise known as MBRP, which is a type of CBTRP. And I want to note the reason that we added this focus on MBRP was for a couple reasons. The last few times that we've done this presentation, people have had a lot of questions generally about how to get training, as well as specifically about MBRP, because it's kind of a hot topic in the last few years. And when we went to look for training opportunities for folks, we found that MBRP is much more accessible in terms of training. So we wanted to add that in as a focus here so that you can get a little bit of an introduction. And if it's something that seems interesting for you or your organization, we have some resources at the end as to where you can get more information and some training. So we'll start out with the stages of change model, which will look familiar to most of you. This is really about conceptualizing the different sort of intervals that people go through in the process of recovery, and where the skills that we'll be talking about today, the relapse prevention skills, will fit best. So if we try to give relapse prevention skills to people who are in pre-contemplation or contemplation, where they're either not thinking about change or really very ambivalent about it, it's just not going to land. It's not going to be helpful for them. Where it works really well is when they're already moving from the action to the maintenance stage, which is to say they've already made some changes, they're invested in preserving those changes, and they have a vision for themselves of recovery long term. And the relapse prevention skills are what you're going to build up to help them protect what they've invested in and to reach that vision. So with that, what is CBT? It's a therapy that addresses the reciprocal links between thoughts, feelings, and behaviors. I'll talk about that more in a moment. It's important to note CBT is really, really well researched across a number of disorders. It has good evidence for treating substance use disorders of all types, as well as for dual diagnoses, importantly. It's a really flexible model, and you can implement it in a variety of settings. So it's very popular in hospital-based and primary care settings. It is short-term, it's very highly focused, so it's very skills-based and psychoeducation-based. And of course, importantly, it works in combination with medication. So as far as the sort of conceptual map of CBT, this is where we see that the cognitions, the behaviors, the emotions, and also physiological sensations are all reciprocally linked. You can see that those are bidirectional arrows. So the idea is that each component influences another. And as the name suggests, with CBT, we're really looking to intervene at the juncture of either cognition or behavior, because we do find that acting directly on emotions and physiology is much more difficult, if not impossible. But the idea is that when you can change cognitions and behaviors from maladaptive to more adaptive ones, then you're able to change the flow of the whole cycle and accordingly change the downstream outcomes. You'll notice on the outside of that model is the environment, so the activating trigger, the critical incident. And I do want to differentiate that it's not always something that is external that's the trigger. Very often, especially for patients with substance use disorder, it might be something internal, such as a memory. But again, the idea here is that we want to intervene and change cognitions and behaviors in such a way that it's going to produce a more favorable outcome. The sort of extra layer that a mindfulness-based approach takes here is really just about slowing down and stepping back in order to better recognize the components of these behaviors or of this cycle and how they fit together. So we'll look more closely in a moment about what that actually looks like on the ground. But the idea really is that these are linked so tightly for most people, especially around repetitive triggers, that we're really not aware of how it happens. We rarely can recognize that link between the first thought that we have, how that leads to, for example, an emotion. For example, we have an anxiety-provoking thought. That, of course, brings up anxiety. In turn, our body responds by giving us physiological cues associated with anxiety, such as increased heart rate or sweating or flushing. And that in turn might cue us to engage in some behaviors that reflect that sense of urgency that may actually not be real, may actually be maladaptive. And if we can intervene at the top to interrupt the anxiety-provoking cognition, then we can change it. And with mindfulness, the idea is all about slowing down these different components so we can see them as they happen and make purposeful decisions about how to respond. So with that, what is mindfulness-based relapse prevention? Again, I want to emphasize it's a type of CBTRP, so it's not actually different. It's just a specific CBT model that integrates mindfulness practices into those classic CBT relapse prevention skills. It was originally developed because there was a recognition that cravings and negative affect play a really outsized role in the relapse process, and these mindfulness skills really target cravings and negative affect specifically. So some of the main tenets of mindfulness in this context are about awareness. So the quote is often noticing on purpose and in a particular way. And with that, making a change from responding to reacting, because what we find is that when we are directing our awareness judiciously, then we are able to interrupt the sort of automatic pilot mode that many of us go into around habitual or routine behaviors, and we can make mindful, in other words, purposeful, thoughtful decisions about how we want to engage with our environment, with a precipitating event, et cetera, rather than reacting in a very habitual or reflexive automatic way. An important tenet that goes along with this is changing our relationship in general to discomfort. The idea there being that in Western culture, especially, we often kind of implicitly learn that negative or uncomfortable experiences are things that we should avoid or suppress or shut down as quickly as possible. And a mindful approach invites us to make space for those difficult feelings and be with them in order to respond more thoughtfully. Self-acceptance and compassion are a really important part of a mindfulness-based approach. That's about, forgiving ourselves, having compassion for ourselves in our very human errors and weaknesses, and being able to accept ourselves as we are. This is part of the mindful part of sort of not fighting the things that we dislike about ourselves per se. And then the larger global part is that lifestyle balance. So that's having the ability to mindfully choose how we can care for ourselves best. And you can see how that would relate very directly to substance use disorders and relapse prevention. So again, as we go through, we're just going to have a brief focus on a sort of mindfulness-based approach. So I won't dive into the interventions, but I'll just give some examples of MBRP interventions that correspond to the main principles of CBTRP. So with that, some general considerations for CBTRP. One is the importance of repetition. This is for a variety of reasons, the most important being that chronic substance use often does cause cognitive deficits, especially in memory. So there's very concrete reasons that patients have a hard time initially integrating the material. But of course, as we know, substance use habits are very deeply ingrained. They've cut a very deep channel into the brain. And so it takes a lot of time and effort and energy to reverse that and to come up with behaviors to compete with it. So that's important to remember as a provider and to communicate to the patient, because it can be really demoralizing otherwise to keep returning to the same concepts over and over if you don't realize that that actually is an important part of how this treatment works for most people. Providing a clear rationale is a really essential part of any type of CBT, because with CBT, the majority of the transformative work takes place outside of session. There's a lot of assignments, so activities that people do outside of session, and they're unlikely to make progress if they're not engaging effectively with those assignments. And they do take a lot of time and effort, so that's why you don't want to send a patient out into a week with a bunch of assignments without having communicated very clearly, this is how this is going to address your presenting problem, this is how it's going to help you reach your goal. You really don't want them going out there thinking, my therapist just gave me something strange to practice. So you want to make a really clear link between their goals and how this activity is going to help them reach it. And you want to really constantly reiterate how important it is that they stick with the activities outside of session, because that is where the change happens. So accordingly, monitoring is a really important part of that. You're wanting to make sure that at the beginning of every session after agenda setting, that you're checking about how the activities went that week. You're asking not just, what got in the way if it didn't get done, but also what it was like for them, because you want to be with them to troubleshoot anything that's getting in the way. And you also constantly want to meta-communicate that that practice outside of session is the most important ingredient in successful treatment. You really want to make sure that they're not doing the activities and not getting reinforced for it. And then the last one, and I'd say this is kind of my favorite part about CBTRP, is praising successive approximations. This is about really keeping the patient's morale up in a long and difficult process. And a successive approximation basically just means a small piece of any larger behavior rather than the entire behavior itself, because that's often where you're going to first start seeing change is, not at the sort of end goal, but little steps towards it. And you want to make sure to really highlight and reinforce that all along the way so that the patient recognizes that they are making progress, even if it feels slower than they expect. So in terms of the classic model of CBT for relapse prevention, the idea is that relapse is caused by several sort of proximal or immediate determinants, so things that sort of come up in the moment or come to bear in the moment, and that includes high-risk situations, so that's sort of a constellation of trigger-filled events, coping skills deficits, positive outcome expectancies, briefly means that the person at that moment is concentrating more on why it's going to feel good to use and why it's going to be good for them to use in that moment rather than being able to recognize the sort of longer horizon of all the reasons that it's not going to work out very well for them. And then I'm going to pause with abstinence violation effect because it's such an important one and give it a more detailed definition because the abstinence violation effect is one of these rare verbal strategies in treatment where just predicting and thinking through something that is likely to happen can have a huge role in preventing it from happening. And so the abstinence violation effect is the very, very common human reaction to having a slip or a relapse, which I'll remind you all, as you probably know, that that is the norm rather than the exception. To have the reaction of, I've lost it all. There's no point in going on with these difficult new, health behaviors that I've acquired. I'm just going to go back to my old way because I messed up and all of my hard work is for nothing. And that's such a common thought for people to have that when you can predict it ahead of time in the safety of your office and talk it through with the patient, have them, think through what is this going to sound like for you? What will it look like for you? And then have them question it. Is that going to be true in that moment that it's all for nothing or that you have to give up all your hard work? Then they're equipped when that moment arrives to challenge that thought because the reality is with a slip, they still have that opportunity to get back on the path to recover. They don't need to let it turn into, a full-blown relapse, even though that thought is going to tempt them to. So a really important verbal strategy there is just giving psychoeducation about the abstinence violation effect and talking through with them, what kind of a decision do you want to make when that thought comes up? Then on the other hand, the sort of longer running, more sort of chronic factors that are called covert antecedents that can make people vulnerable to relapse are lifestyle factors, of course. So things like how they manage stress or who they're spending time with, whether they're people who support their recovery or not. And then, of course, urges and cravings. And those are the pieces that we're going to spend most of today looking at, how to manage the urges and cravings. So to understand urges and cravings, it's important to move upstream a bit and see that all urges and cravings are preceded by a trigger. And once we can understand and identify both the external and the internal triggers for urges to use and those thoughts and cravings, then we can interrupt how that transforms into the using behaviors themselves. So for me, it's easiest to conceptualize it as a chain with the trigger at the top of the chain and then links between trigger, thought, craving, and use. And you can interrupt at any point in those links. An important sort of conceptual point to remember is that the further upstream you intervene, the easier it's going to be for the patient to be able to avoid using. So when there are cases that it happens to be easy for a person to avoid a trigger, I always encourage them to do that. That's just the best mileage for their money, so to speak, is to just be able to avoid the trigger in the first place. That being said, people's worlds get really, really small if they focus just on avoiding triggers all the time. So it's really important that they have the skills that move downstream from there. So that's what we'll talk about here, is how to interrupt at those various links in the chain. So in understanding how triggers get formed, how associations with substance use get formed, we're just going to briefly look at an experiment that I assume everybody has heard something about. This was Ivan Pavlov's classical conditioning experiments, where he paired an unconditioned stimulus, meaning food, with the salivating response of a dog. So in other words, dogs are going to salivate when they smell or see food without any kind of training or conditioning. That's just what they're going to do as a physiological response. Then in that situation, he paired what's called a neutral stimulus, which is a whistle. So the dogs had no preconceived notions or associations with this whistle, He paired that with the food until the whistle itself became a conditioned stimulus, so that the dogs were conditioned to salivate when they heard the whistle, regardless of whether or not the food was present. So I think probably the parallel to substance uses is somewhat evident here. A really important distinction here is that substance use or illicit substances are so potent and so fast acting that the brain can form associations. They can form, a conditioned stimulus association almost immediately, perhaps even the first time that somebody uses substances. And so when somebody uses substances in a repetitive context, then a lot of cues get merged into that associative process. And that's part of what makes it so hard with identifying triggers is that there are often ones that are really obvious, like the implements that are used, like a pipe or a lighter or foil. But then there are also kind of less tangible things like the time of day or the people that they tend to use with, or internal triggers, or it could be, that they often use after work, this sort of thing. And those are a little bit more elusive and hard to pin down. But I think this is important to remember not only to structure treatment effectively, but I think as far as carrying empathy as a provider for how difficult this process can be for those in recovery, just considering the fact that the world looks really different to somebody who's in recovery because we might walk into a room and it might look totally safe and innocuous to us, but it's possible that it's filled with these kind of trigger landmines for people who have been using, and there's something in that environment or many things in that environment that are immediately causing them to experience cravings and urges and getting that whole circuitry moving. So how do we apply conditioning to treatment? The first step with CBT is always to use a functional analysis. I'll show you that in a moment. That's where we're kind of mapping out people, places, and things, as well as internal triggers to be able to identify what is it that gets the cravings and the urges going, both in terms of individual triggers and high-risk situations generally. Then we map out both what are the positive consequences of use, which are pretty much always short-term. So that's what feels good in the moment about using it. And then also the longer term negative consequences that are leading them to be interested in recovery. Then based on the information we get from the functional analysis, we're going to review and we're going to develop positive reinforcements and meaningful alternatives to substance use. And this is really about helping people make a shift towards other ways that they can take care of themselves to replace how they've been using substances to respond to certain, emotional or physical needs. So this is what a basic functional analysis looks like. You can see we have external triggers, so that's the who, what, where. We have the internal triggers, so those are things like thoughts, feelings, and sensations. Behavior really kind of maps out, frequency and quantity of use. And then the short-term positive consequences is something you tend to work through over time because usually this column, the patient can think of fairly easily. That's all the different dimensions of why it's pleasant or appealing to use. And then they tend to have a harder time initially mapping out those long-term negative consequences. So what are the ways that it interferes with their long-term goals, or how does it conflict with their values? And what you'll find is that when you work in a family context, it's very easy for their loved ones to identify the long-term negative consequences, but they tend not to understand the short-term positive consequences, and vice versa for the patient. So that's an important part of kind of illuminating the process for both the patient and their family. And the short-term positive consequences are a very important part of developing contingencies. So in terms of a mindfulness-based intervention that corresponds to the functional analysis, an ongoing intervention is called sober breathing, and that's an acronym that starts with S for stop or slow down. I want to emphasize that with sober breathing, this isn't something that we say, go out and use this in a high-risk situation right away. It's something we have people practice with on a daily basis in low-stakes situations so that they get a feel for it and are able to work up to things that are more difficult. So with S, stop or slow down, that's just about first recognizing that it's a difficult situation and kind of checking in. So that first step is about stepping out of automatic pilot and bringing awareness to the moment. Because what we find is that for most people, and especially people who have substance use disorders, there tends to be a really quick link between, a difficult situation and kind of jumping to conclusions about what they need to do. The O is for observe. So that's, again, stepping back, observing in the totality what's happening in the moment, including body, thoughts, and emotions. Then narrowing the attention entirely to just breath. focusing on the sensations of breathing. Then after a bit of that, re-expanding the awareness to include not just one's body, but the experience, the situation, holding it all together in awareness. And from there, choosing a response mindfully. And that has to do with choosing what's going to be best to take care of oneself in that moment and long term. So it's a much bigger picture evaluation than just that kind of habitual reaction of something bad is happening, I need to stop it. So this is a really, really abbreviated script. This is not how I would introduce it to a patient, but just to give you an idea of what sober breathing looks like and how it pairs with functional analysis to help people recognize, what is a risky situation and what can I do to step away from my normal response, my habitual response to it. So in terms of understanding behavioral contingencies, this is really about illuminating those connections between urges to use and using. And an important principle to kind of understand at the outset here is that both positive consequences, which for our purposes today we can think of as rewards, and also negative consequences, which we can think of punishments, they both can change behavior, but positive consequences, rewards, overwhelmingly are more successful at sustaining behavior change in the long term. It's a bit complicated, but the big idea here is that punishments tend to just kind of temporarily cover up or suppress negative behaviors or maladaptive behaviors. Whereas when we can reward people for adaptive behaviors systematically enough, that can outcompete the maladaptive behaviors and those diminish and disappear. So this is important to remember, again, not just because it's important to understand the theoretical underpinnings of the treatment model, but also because we're working against a really strong societal anachronistic impression that we can punish people out of substance use disorders. And we know that that's not true based on the evidence, but it's still a really, for some reason, a very appealing thought to a lot of people in our culture. And patients internalize that and they think they can punish themselves out of substance use, but that just creates a lot more negative feelings that then prompt them to use substances. So we really want to help explain that part of the treatment is about shifting from punishing themselves to finding out how to reward themselves for engaging in the kind of behaviors that reflect who they want to be and that align with their behaviors or with their values, sorry. So to that end, we've talked on this echo a lot about contingency management. That's the idea of formally managing those contingencies. You always want to select a target that's reasonably objective and easy to measure. So behavioral targets are great. Attendance and abstinence as verified by UDS are great targets. When patients meet those targets, then you give them a tangible reward. So that could be something like a voucher or an opportunity to win a prize or maybe privileges like take-home doses. But the idea is that substance use itself is so reinforcing that we're trying to scaffold people towards those more adaptive behaviors that can compete with substance use in an explicit way, because at the beginning, it's going to be really hard for them to move from that immediate, really potent reinforcement of substance use towards the much weaker and diffuse reinforcement of, doing the right thing and doing what's in line with their values. So to that end, in CBT, you're pretty much always going to incorporate the alternatives to use table. This is again about helping them to recognize what are different ways that they can take care of themselves and address difficult feelings or experiences without using substances. So you have on the one column, what is the trigger situation and what would be the positive consequence of use if they were engaging in the old behavior? And then what is an alternative activity that has a similar positive consequence? I really want to emphasize it's not going to be of the same intensity or magnitude as using substances, because it's important for providers to communicate that they understand that something like taking a walk or having a nice warm bath is not going to be exactly the same as smoking fentanyl. Of course it's not, and patients won't take us seriously if we say something like that. We try to situate this within the larger context of helping them learn how to make this kind of almost paradigmatic shift from thinking I can solve these problems by using substances to there are other ways to take care of myself that are more sustainable and that fit better with my long-term plan for myself and my values. So how MBRP fits in with alternatives to use, the relapse cycle worksheet, I'm not going to go in detail into this, but you can see it's a way of mapping out both what has caused relapse in the past and what people prospectively anticipate might cause relapse. And it starts with a trigger and an initial reaction, and then it splits into two decision forks. The lower one being what is the old way, what is the automatic pilot way of thinking and then reacting. So the person maps out what are some of the thoughts that come up associated with the trigger, what is the automatic reaction, and usually that encompasses use, and then recognizing how that feeds into a recursive loop of often then feeling badly about having used and then using again, etc. And then the upper path is the mindful approach, where, for instance, they might use that sober breathing technique to stop, observe, breathe, evaluate, and then respond. The main idea just being that they step out of the automatic pilot mode and take a moment to really evaluate what's going to be most important and what's going to be most helpful in taking care of themselves long term. In terms of urge management, this is about both identifying the urges and then figuring out how to modify them before they turn into using behaviors. So this is the most basic version of a daily record of urges, just date, situation, intensity of cravings, and then the coping behaviors used. And then this is the MBRP sort of analog of that, called the Noticing Triggers worksheet. So you can see here, there's day, situation or trigger, sensations experienced, mood, feelings and emotions, thoughts, and then response. There's a lot more emphasis on the different kind of dimensions of the internal experience, and that goes along with the mindfulness skills training of being more tuned into what's happening inside, slowing the process down, and making a mindful decision about how to respond to those in a way that takes care of themselves best. So once people have begun the process of logging and mapping their urges, then we can start with urge modification skills. And urge surfing is one of the most popular ones. This is a great reflection of the mindfulness-based approach. Again, I'm not going to introduce the intervention in its entirety, just kind of an idea of how it works. But you start by explaining to patients that when we try to fight urges directly, kind of head on, it's much like trying to fight a wave in the ocean. It's going to take a whole lot of energy and you're likely to lose in the end. Whereas if you can surf over them, then you can kind of just ride the urge out. So an important part of that is just the physiological psychoeducation that the body is not capable of sustaining an urge for longer than about 30 minutes on average. So that if they are able to just ride it out, or in some cases just delay if they're early in recovery, that urge will peak and subside within 20 to 30 minutes at the outside. So the skills have to do with being able to tune in, notice the urges, and just observe them rising and falling like waves without actually responding to. It's important to educate patients about the fact that this is a practice that gets a lot easier with time, both in the sense that they'll, integrate the skill, but also that it helps our brain to reduce the urge itself. So the waves get smaller, so to speak, the more practice we have surfing them without giving into the urge. Again, this is all rooted in being able to log and identify the urges effectively. So a really great modular intervention with relapse prevention is high-risk situation planning. This is something that you can really take out of the model and use even if you only have a very brief bit of time with the patient. This is really about identifying the context that's most likely to increase their vulnerability to relapse and planning to allow them to respond effectively. So this sounds really basic, but it's actually a game changer for a lot of patients. And that's just about shifting the amount of time that they spend in high-risk situations more towards low-risk situations. I know it sounds really basic, but when you can support patients with planning to do this, it just makes it so much easier for them because they're not expending all their efforts trying to manage the triggers, the cravings, the urges that come along with high-risk situations. So this is what a high-risk situation planning sheet looks like at its most basic, literally just listing out, in this next week, what are going to be the situations that are going to be most difficult for you? How can you handle them? And you're troubleshooting this with the patient ahead of time. The main idea being you don't want them to have to improvise in the moment. You want them to have had the advantage of thinking through it ahead of time and having had, another pair of eyes on the situation for suggestions. So once you fill this out, you have them, physically take it with them. You have them take a picture of it on their phone. You really want to make sure that they have it queued up and at the ready once they're already in that situation so they don't have to improvise. So the MBRP component that corresponds here is using that sober breathing space in challenging situations. And this is actually one where people are ideally mapping out in real time what is the situation or trigger, noticing all of those internal reactions as well as what's going on in the environment, checking whether or not they were able to utilize that sober intervention, and then how did they respond from there. And this is a great data gathering kind of approach for people then to be able to fill out the high-risk situation planning worksheets much more thoroughly and with more nuance, understanding, where they're at their most vulnerable and how rewarding it is when they're able to respond effectively. So what goes along with that is the skill of helping patients develop a plan. Again, that sounds really basic, but for a lot of patients in recovery, this just isn't a skill they ever had a chance to develop. And unstructured time is a really vulnerable time for people in recovery. Usually, seeking and using substances has taken up a lot of their time and energy in the past. So when they're in recovery, sometimes there's a lot of unaccounted for time. When you can help them plan that out in a way that provides them with plenty of appealing and accessible non-using behaviors, it dramatically improves their chances of being able to stick with the plan. And you do want to always remind them, give them the rationale that if they follow that schedule, they're much more likely to avoid triggers in using. So in wrapping up, I do want to note, we do know that slips and relapses are the norm rather than the exception. That's an important thing to remind patients so that they don't take it as a personal failing. So anticipating that, you can sort of go over the cognitive structures of response to a slip. One being it's a mistake, two being it's a mistake from which you learn something, three being it's a hopeless disaster. Of course, the hopeless disaster that goes along with the abstinence violation effect. If people think of it that way, then it's much more likely to lead to relapse. Whereas if you can talk through it ahead of time and say, hey, if you have a slip, that's part of all of this, logging and, sort of detail orientation that we've been getting into about what makes you vulnerable. Now we have more information. Now you're better prepared the next time that trigger comes up. So as far as the interventions, what do we do after a slip? I'll say this was developed decades before MBRP came out, but you can really see the precursors here in terms of the most important components of responding. One is don't panic. Don't give into that sense of urgency that usually comes up around a slip. Two, stop, look, and listen. That's about interrupting that ongoing flow of events so that you can think more clearly. Three, remember that abstinence violation effect. So really be able to, think through what you've already discussed about that. Four, renewing your commitment to recovery. And then five, deciding on a corresponding course of action. And the MBRP intervention that goes along with that is this reminder card. This is usually filled out towards, I think, the 7th or the 8th session in the group. So it's as they're getting ready to graduate. And it has the sober breathing reminder on there. Then it also has their self-generated selections for what are their reasons to stay sober, what are the contact numbers of people they can depend on to help them with this in a difficult situation, and what are their alternative activities or plans that are going to help them get out of that situation and take care of themselves more effectively. So to wrap up, we wanted to include some links to MBRP resources. These are background of the practice, materials, trainings, recordings, and handouts. And I especially want to draw attention to that last link. That's actually Dr. Witkowitz's lab here at UNM. And it's not only a lot of interesting research on MBRP, they also offer a free group of MBRP with rolling admission. And it's actually open to any New Mexico resident that has an internet connection and has a private space. So if you have patients that you think might benefit from this, I really encourage you to check it out and set them up.